So for those of you who don't know me, I think I know most of the faces here, but I'm Jarek Menkedick. I'm one of the MS doctors here. I know. How are you, Candy? Thank you for coming. So we're gonna go over a little bit about MRIs and MS, and I have some pictures, and I want to try to make it a little bit interactive. So if you guys have any questions for us as we go through, please reach out and let me know. First thing I want to talk about is a little bit of, and you'll have to bear with me a little bit as I get into some MS pathophysiology, or a little bit of how our immune system works. I think it's important because it allows us to understand why some of the findings happen on the MRIs and why we get some of the changes on the brain if we understand a little bit about why MS happens in the first place. So on a very kind of broad overview level, our immune system is made up by these things called T cells and B cells. So the T cells, very broadly, are things that attack. They want to attack bad bacteria, bad viruses, parasites, things like that, which is really good. They also attack things like cancer cells, and they help control our body's natural propensity to produce abnormal cells and keep them from not becoming a problem. That's what happens with cancer, is when cells propagate and they're not controlled. So that's one of the functions of our immune system. Now, B cells, they stimulate, those are the other big cells. So they stimulate different types of cells to become more inflammatory, including T cells and other, what we call innate immune system cells, which is kind of out of the scope of what we're going to talk about today. But the reason that this becomes important is that it allows us to understand how the damage occurs in MS, and then why sometimes we get symptoms from MS. So this is the structure of what a normal neuron looks like in our brain. And obviously it's simplified, but this is the general structure. It has what's called the cell body, which is where the genetic portion of the cell lives. Let me see if I can get this a little easier. And then it's surrounded by these things called dendrites, and the dendrites are what help the cell receive information from other cells. And then you have this thing called the axon, which is like an electrical cable. And this electrical cable then transmits information from here all the way down to here. And then this is what is the synapse. And so this is where the nerves talk to one another. So let's imagine there was another cell right here, and it would attach right there. And that's how the cells talk to one another. Well, what happens in MS is you have this stuff called myelin, which are represented by these gray nodules right here. And these gray nodules are actually supplied by a different cell, which I have up here, called an oligodendrocyte. So there's one oligodendrocyte, that's the cell body, and it's myelinating multiple different axons of the nerves here. What happens in MS is that those T cells that we talked about are becoming stimulated by B cells often, and then they attack either the oligodendrocyte itself or the myelin around the nerves. And this myelin acts like an electrical transport enhancer. So the nerve cells talk to one another through electricity. So when you have insulation on the axon of the nerve can talk faster. So that's an axon and a dendrocyte that is, a neuron that is fully myelinated, and it's conducting electricity way faster. Well, in MS and other types of issues with demyelination, this nerve cell cannot conduct electricity like it should. So it's much, much slower, and in some cases, especially with chronic MS, this cell will start to die off because this nerve axon can get damaged. So that's one of the reasons that we think that people, struggle a lot with MS. And I think that this is a really good explanation also of why, people have a lot of fatigue with MS, because if you get that chronic damage and those nerve cells are not conducting like they should, they're slower than they should, everything is going to be slower, right? And I think that's where a lot of our fatigue comes from, which is tough to treat because we don't have anything that remyelinates those axons. I wish we really did, because if we did, then we'd probably see a lot more benefit with people recovering and getting better from MS. And, as you know, we just don't see that, unfortunately. But now that we have a little bit of a baseline of why some of this, happens in the first place, let's talk a little bit about MRI, and then I'll kind of tie everything together at the end here. So MRI, as you probably know, stands for magnetic resonance imaging, and it's an imaging technique that was developed in the 70s, first in 1977, although some of the early experimentation was done in the early 70s, and then really became widespread use in the late 80s and 90s, and those were some of the first times that we were using MRI to identify MS. Before that, we did have some CT scans, but CT scans are not nearly good enough to pick up things like multiple sclerosis, and MRI is by far the standard, as a lot of you have done lots of MRIs throughout your life. So MRIs use magnets, as the name implies, and what it does is it uses the polarization of water molecules. And so you're kind of getting into physics and chemistry a little bit here, but water molecules actually have a small electrical charge. And so what the MRI does is it helps detect and uses the magnet to send a signal through the tissue, and it can detect the way that the electrical charges are positioned, whether they're negative or positive, to then give you an orientation of where the molecule is and the density of the signal, and it thereby indirectly forms an image that then is processed by a computer, and it gives you what looks to be, our human anatomy without being invasive. It gets a really good picture. So because it uses magnets, it doesn't have any radiation as opposed to CAT scans or x-rays. So you don't have any increased risk for cancer or anything along those lines, with radiation from CAT scans and that type of thing with MRI. So that's at least one positive. That's good. And it tends to be very safe for the vast majority of people. Obviously, there are people out there who can't have MRIs for one reason or another, a lot of times because of cardiac implanted devices or other devices that way. But the good news is the vast majority of people can have an MRI, even if you have, like a false knee, or if you've had surgery and you have plates and screws in your arm. Let's say you broke a bone, for example, then a lot of times those plates and screws are titanium or other types of non-ferrous metal. And as long as it's non-ferrous, even if you have metal, you can still get an MRI. But there's screening protocols, as you all know, to keep it safe. So when you get an MRI, and when we get the pictures back, when we look at them, we have what are different sequences. And so these are basically different ways that either the magnet is measuring the amount of water, or the way that the computer is processing the raw data to then spit out an image. And it allows us, the different sequences are basically like different camera filters. Like if you're on Instagram and you're using a filter one way or another, it allows us to look at the same picture, same data in different ways. And it may help you understand the way that the image looks depending on the filter or the sequence here. So these are very common sequences that we often get during the MRI. So we get what's called a T1 without gadolinium. Gadolinium is also known as contrast. There's a T1 with gadolinium. And T1 sequences are helpful for looking at basic anatomy. They're really, really good scans for looking at, structural changes that may come on. But they're not as good for looking at MS lesions, generally speaking, although we'll talk to that a little bit more. We also get a T2 signal, which is like basically when we look at the computer, it's an opposite of T1. This is good for looking at things like MS and other pathology. We'll see brain tumors, for example, on T2 flare. Not that we're talking about that today, but just to give you guys a little bit more scope. The next is what's called a flare, which is a fluid attenuated inversion recovery. This is actually the sequence that I use the most with MS because it's the most helpful to me. It's basically a T2 image that then they've used some computer processing to make it more clear and more easy to see the abnormalities. And I have a bunch of pictures at the end of the slideshow here. And with this, most of those images will be flare images. And then finally, there's something called a stir image or short tau inversion recovery. This is used primarily in spinal cord imaging. So if you've ever had an MRI of your cervical or thoracic spinal cord as part of your MS journey, a lot of times you'll get a stir image, and that's a really helpful image for us. So these are some of the things that we'll see. And sometimes, even if you read the report, the radiologist will say, on FLAIR imaging, X, Y, and Z. And we'll go through that a little bit as well. Do you guys have any questions so far? Okay, good. So I mentioned contrast a little bit, and the most common contrast is something called gadolinium, which is a metal or chemical that's been processed to be medically safe to give. And what contrast does is it helps us look for evidence of active MS lesions. When the immune system attacks your body, it often breaks down something called the blood-brain barrier. And everybody has this, and it should function normally to keep bad things out of your brain, like infections or autoreactive immune cells. In people with MS, that's not the case. And so you get that breakdown. But when you give the contrast through the IV, it lights up the abnormal area because that contrast should not be able to cross the blood-brain barrier. So when you give it and you have an active MS lesion, it's actually evidence that there's damage there, and that damage is new. So when we give the contrast, it's good for monitoring for new damage, which often we give it when people are first diagnosed with MS because they're having a new exacerbation, a new symptom. So we're trying to figure out why, hey, my right arm is numb and I can't move it all of a sudden. Why is that happening? So that MRI is given with contrast when you're looking for an active problem like a new MS lesion. It's also good for, let's say you have a new symptom and it's completely brand new and you want to see, is there new MS damage? Am I on the wrong medication? Or am I switching medicines and this wasn't the right medicine for me? There's lots of different scenarios, of course, but it's good for monitoring for a new lesion. That being said, as time goes on and people become more stable, sometimes it's not necessary to use contrast, because if you're stable on a medication and it works great for you and you haven't had a new lesion or a new symptom in many, many years, you may no longer need the contrast. And the reason for that, I think, is clear, that it's unlikely to show us anything. So A, I'm giving you and exposing you to a chemical that you may not need. And B, if you do have kidney damage, sometimes there can be long-term effects from contrast. Obviously, we try to test and we look for kidney damage before we give the contrast for safety measures, generally speaking. The other area where this is where screening MRIs come in. If you have what's called a subclinical lesion, so that means you had damage but you weren't aware of it, which can happen. That's why even if you're on a good treatment, we want to do regular MRIs. But if that damage is something you didn't know about, it could have happened 6 months ago, and even if I gave you contrast, it wouldn't necessarily show me or illustrate anything to me, so I may not need a contrasted image. So, and this is something I think that's been coming into the MS space a little bit more, where we're using less and less contrast. So if you see that with your doctors moving forward, don't be surprised. Or if you have been treating your MS for 20 years and you've had 20 contrasted scans, that's okay. Again, the risk is still minimal, but I think it's one of those things that we're going to start moving towards more and more through MS care. The next thing I want to talk about is there's different forms and strengths of the magnets that we use with MRI. A lot of times you'll have been on what we call a 3T, and the T stands for Tesla, like the inventor, the electrical guy, not the car. But it stands for 3T. And that basically looks at the quote-unquote strength of the magnet. Because of the higher strength, you do get higher resolution of the images, so they're a little bit more clear, a little bit more accurate. So they can be really helpful for tough diagnostic cases. whenever we can get a 3T scan, it can be very helpful for us. The problem is they're more expensive. So the machines themselves are more expensive, so less facilities have them, or even if they have them, they have less available machines. So from that standpoint, it may not always be available, or because of scheduling X, Y, and Z, or it may just not be, something where it's feasible from a cost standpoint of wherever you go for your MRIs. So because of that, not everybody gets a 3T scan. By far and away, more people are getting 1.5 Tesla scans. That's far more common, and that's your normal regular MRI machine that probably everybody who has MS here has gone through at one point or another. It has still really good resolution. You can see really good pictures with the 1.5 scan, and most of the time the neurologists and radiologists are quite happy looking at those images because it gives us tons of information and allows us to make an accurate diagnosis. So probably the vast majority of people are getting 1.5 scans. And then finally, there's an open MRI. So these magnets are a little bit less strong. It's usually 0.5 to 1 Tesla, depending on the model. The trade-off there is, of course, it's a little bit less claustrophobic. It's a little bit more open, but you lose a little bit of the resolution because it's not as an enclosed space, and the magnet's not as strong. So good for people who have issues with claustrophobia and other problems. You can still get good pictures. They're not quite as good as the other scans. So next, let's talk about an MS lesion. So also known as a plaque or sometimes a scar. There's lots of different names for these, but generally speaking, a lesion in the world of neurology, and we'll use this not specifically to MS, but a lesion just indicates an abnormality within the brain tissue for one reason or another. So it is a non-specific term, meaning we're using it to say there's damage in this area, but we may not know what that damage is from. Once you get a diagnosis of MS, then it becomes more honed in, and that lesion is then referring specifically to an MS lesion or a lesion caused by MS at this point. With these MS lesions, the reason they show up is because of that damage. We talked about those T cells attacking those cells, causing that damage. And then sometimes we do see, as time goes on, the scarring down of that tissue. So let's go over some images. Let's see. So when we get a picture of a brain, this is what it looks like, and this is a normal brain. There's different ways that we look at the images themselves. This is what's called an axial view. So in other words, we're cutting across the top of the head like this, okay? And when they shoot an MRI, when they do the picture, they actually shoot it from the bottom to the top. So when you look at it on the screen, it's flipped. So even though this is the left side of the screen, this is the right side of the brain over here, and vice versa. So this is the left side of the brain. The nose is always oriented to the top of the screen, and the back of the head would be here, and then your ears would be over here and over here, although you can't see them in this picture. So this is what a normal tissue brain would look like, and this is that flare sequence that I talked about earlier, which is good from an anatomy standpoint. It looks at good anatomy. It also looks at good pathology, including things like MS. So
no lesions.
This one is completely normal. There are no lesions on this brain. This is what's called a sagittal view. And a sagittal view means that if you were, imagine you're slicing across the brain like this. Oh, and I forgot to mention, MRIs, what they do is they take small little tiny slices. Like you imagine a deli slicer, you're going same thing on the head where it's going, or in this case, it's going, okay? And so on this one, it's shooting from like this. So you can see the person's nose right here. Here's this person's tongue and their lips and their mouth. And this is their sinuses and their, their esophagus where they can swallow. And then here's obviously the brain. And this would be someone who's, straight down the middle, essentially. So you're looking at the very middle part of the brain. So that's what normal looks like on a very basic level. And you'll notice the normal tissue is kind of this gray-white color, but fairly uniform, generally speaking. This black stuff that you see in between the individual parts of the sulci, that's the walnutty part of the brain, is something called cerebrospinal fluid. It acts as a shock absorber, helps provide some nutrition to the different parts of the brain, and that's all normal. This is a picture of a normal cervical spine. So in this image, again, you can see, and it's shot sagittal, so it's shot like this. This is the spinal cord itself. It's this nice kind of fairly uniform gray color. Because this is a T2 image, the cerebrospinal fluid, instead of being black, is white in this particular image. You guys don't need to really understand that, but I'm letting you know. So that's normal. And then these are the bones. This is the spinal column. And again, this is just a normal MRI. And here's a picture of a normal thoracic spine. Here's the spinal cord. Again, it's coming down. It's this nice uniform gray color. And then it's surrounded by this cerebrospinal fluid. Okay. And here's the bones. And this is the chest cavity. Okay. So now that we've looked at some normal, we'll look at some abnormal brains. So these are all MS, specific. Okay. So our first one, this is a FLAIR image. Again, we're shooting from the bottom up, and this is an axial cut, so we're slicing like this. So this would be right about here.
And the right side is still the left side, and the
correct.
Left side is
So
still
this
the right
is
side.
the left side of the brain, even though it's on the right side of the screen. And this is the right side of the brain. Okay. So here we see our first MS lesions, which in this case, in this particular sequence, show up as these white spots. Yes. And so you'll see this person has 1, 2, 3, 4, 5, 6, 7. And this is probably an old one that we're picking up 8 potential MS lesions just in this one slice. So this is what we're looking at when we see this. And this would be a very classic picture for someone with multiple sclerosis. You can also get an appearance like this, where the lesions don't look quite as bright and not quite as well defined. Do you see this, how there are very clear borders on, like, for example, this lesion and this lesion? But here, in this individual, you get less defined, and they look less bright as well. Here's some pictures here and here. Doesn't necessarily mean that this person has worse or better MS, but it just illustrates that it's not a one-size-fits-all. And I think it just illustrates, again, that, we're looking at these lesions here. Yeah. So if I saw this picture and this picture, they both tell me that this person has MS, but past that, that's where, a picture is just a picture. Okay. And when we're making a diagnosis, when we're evaluating patients, we have to really put together both the person's symptoms, how they're feeling, how they're doing, plus the data, the MRIs and those types of things. And then we're, putting that together, making a diagnosis, making a plan for that person in particular.
Is the difference because of the type of machine the MRI was done on, or is it the brain just looks different?
I think in this case, it's more like the brain just looks a little bit different, although it does get to a good point where if you can, having the same type of machine and doing it on the same machine regularly helps keep consistency, because there can be slight differences in calibration and other technical factors that can occur. So that's where, if you're able to be on the same machine every single time, it can be helpful, which I was going to mention, so thank you. And some of these pictures I took from the internet, some of them are my patients. This is one of my patients. Here is another MRI of the brain. This is again another slice like this. This one's a little bit lower below the ear.